David Rottenberg. He is a Chief Analytics Officer at KMH. KMH has a special place in my heart because they helped us get our HIM 7 when we first went for it in 2018. So David is going to talk to us about mental health data from fragmented to fundamental, integrating data into actionable intelligence. So come on up.
Thank you very much. Well, hey everyone. It's great to see everyone who made it in today. A little slushy out there. So my talk is actually called Synapses, Not Silos. It's a little biological, maybe a little bit different today. And just to reintroduce myself, I'm David Rottenberg. I'm the Chief Data Analytics Officer at the Center for Addiction and Mental Health, the largest mental health hospital in Canada, one of the largest in the world. And I also co-direct the Krembil Center for Neuroinformatics. That's at the intersection of computation and neuroscience. And our team has been working for the past several years on how to build data systems to help tackle the national and global mental health crisis. It is something we see as a foundational challenge of our times. So first of all, a huge thank you to everyone from yesterday. That was really fantastic. The talks, the speakers, the panels. It was really great to see all the insights and a shared understanding of the challenges that we all face in this healthcare sector. Data quality, modern platforms, building new infrastructure, dealing with our infrastructure debt, very acute in mental health. Moving from pilots into implementation, the challenges in doing that in a way that is coherent, that brings about actual change. Establishing governance and trust, and using that to affect culture, change, and adoption of the tools that we create together. So I couldn't be thankful for a better foundation, or more thankful for this. So at CAMH, we focus on the treatment of mental health and addictions disorders. And it's our shared belief that mental health is the ultimate measure of quality of life. It reflects everything that we experience, we remember, and we hope for. And in my experience, it impacts all of us. Friends, families, our communities. It's really ubiquitous in our society. 1 out of 5 people will suffer from a mental health disorder in their lifetime. Now, when people arrive at CAMH to a clinic, they actually have a combination of different types of ways they're presenting. And you can see here there's this 3-dimensional overlap of different conditions that makes it very difficult to disentangle these from symptoms alone. And to make it more complicated, someone with depression often has anxiety. They may have trauma. They may have substance use disorder. They have this multidimensional experience they're bringing when they're arriving at our hospital. The situation is even more complicated over time. There are different developmental stages at which these disorders peak. And as you can see, many of them actually occur in the youth population. And that's where we're putting a lot of our focus strategically today. But that also means that disorders that happen early in life are carried forward throughout the entire lifespan. Now, like other organs, there's a multi-scale nature to the brain, but it's even more complicated in the way it manifests our cognition and our experiences. We have a link and the need to study the genes that create the cells, their individual morphology, how they create microcircuitry, the entire structural manifold, whole brain dynamics, and then how they're ultimately seeing and interacting with the world. And so while, of course, in other diseases and other disorders, you have to have ways to manage these types of data, mental health requires multi-scale, multimodal, longitudinal data management. So in reality, in our sector, in mental health, here's what typically happens. Here's Sarah. She's arriving at the ED in crisis, 20 years old. The physician pulls up the chart and they see some information. They see medications, fluoxetine, 40 milligrams daily, no documented allergies, a little bit about the clinical history, 3 ED visits, last visit was 6 weeks ago. And these are facts you'd expect to find from a database, but it's obviously very limited. And here's what they don't see. Brain imaging from a study a year ago that showed challenges with the hippocampal volume that's a key indicator of treatment-resistant depression. biomarkers that suggest she may be a poor metabolizer of this drug. The reason it's not working for her body can't break it down. Social determinants, housing instability, food insecurity, and a call to 988 4 weeks ago. All these data are there, but they're invisible to one another, generally speaking. And this is something we've all experienced in healthcare, a fractured system of data that, if it were brought together, would of course have a profound change on patients and how we're delivering care. Now, in many respects, they're phenomenal technologies, but the way in which we've gone about designing our systems is a little bit like filing cabinets. And I think you've all experienced this based on the talks from yesterday. Things are fragmented, dashboards are often after the fact, AI pilots are disconnected from what's actually happening in that moment, and we have these issues of latency, context loss, and siloed intelligence. Now, shifting gears a little bit, I said this would be biological. There's a fascinating field of biomimicry, which is where we use the principles from nature in what we design and manufacture. Aerodynamics from birds, material science learning from spider silk. It's really everywhere when you start to look for it. It's really fascinating. Now, this is Dr. Santiago Cajal, and before his work, and he's considered the father of modern neuroscience, people thought the brain was just this continuous blob of tissue. But as you can see from these painstaking hand-drawn diagrams, there's a structure there. There's these fine neurons and synapses that are connecting together, and for this work, he won the Nobel Prize in 1906. Now let's fast forward. You're probably more familiar with Dr. Geoffrey Hinton, who won this year's Nobel Prize. And he was inspired by that biomimicry, the actual structure of how neurons work to bring information together to then pass a signal forward. He turned that into mathematics, and that was a key insight that has driven us all forward. I think you know how that went. We now live in a world suffused by AI. The game of Go, for example, was thought impossible for machines to tackle. AlphaGo mastered it. Art, #1 musical hits, literature, it's everywhere. And it's driven by this fundamental insight of how the brain actually works. And so I'm going to borrow this quote from Dr. Hinton. Intelligence emerges from connection patterns. Not just storage, not just compute, although those are necessary, but it's the connections that are critical in creating meaning. And so at CAMH, at the Crumble Center, when we're designing our systems, we asked ourselves, what happens when we use neurobiology as a blueprint for our healthcare data systems? So I talked about the synaptome, that's the synapses and how they present across the brain. The next level up, conceptually and structurally, is called the connectome. And that's really the wiring pattern of the brain. This is what I spent my grad days doing at Sunnybrook Hospital, was creating these images. It's called diffuser tensor imaging, and what you're seeing are the white matter tracks that are connecting the regions across your brain. It's linking concepts, capabilities. It's really a network that suffuses everything that we're thinking right now. And as you can see, this is not a spreadsheet. It's a graph. It's made of nodes and edges that are connecting these things across the system. That's how the brain is able to process what it's processing. And so taking inspiration from that, a knowledge graph is the way in which we wanted to design the way we're linking our information. Now, many of you may be familiar with the pros and cons of knowledge graphs and relational databases. For our purposes, knowledge graphs help us link relationships between entities and ask questions like, show me the patients that have similar trajectories. Show me the medications that lead to remission, relevant for us in that moment. Relational databases are excellent for many things, and we still use them with lots of different use cases. Excellent for billing, claims, accounting, with very structured schemas. But we feel, and you may agree, that healthcare is very dynamic, and therefore we want our capacity to be dynamic as well. And so that's what we built. At the heart of what we've developed is a knowledge graph that is built on global standards, consensus-driven, that allow us to build a backbone on HL7 Fire for the patient context, but then link in all of these different modalities that go into that multi-scale, multimodal nature of studying the brain in context. So neuroimaging data, electrophysiology, morphology of those individual cells, genomics, wearables data in this unique complex representing a mental health context. And so what this allows us to do is to connect a patient in the center with the information from their records, with measures they're responding to, their personal reflections, and also to the research studies we're conducting at the hospital. Now, there's governance in play, of course, it's not all visible at one time, but this allows us to make that connection and have not just a patient, but a patient participant across their entire journey through our hospital. Now let's go back to Sarah. She's back at that ED in that moment of crisis. Through the knowledge graph we developed, we're able to create visualizations similar to this that let us see the symptom severity over time. You can see it's getting worse. We're surfacing that pharmacogenetics insight about her being a poor metabolizer. We're seeing the medication time course, instances of suicide risk, and bringing that directly at the point of care, embedded into the chart. And so we've launched many of these across our hospital in different departments and clinics to help them make decisions in that moment. Unfortunately, there are still a lot of challenges with knowledge graphs, and as you'll see, it's with the design. So for flowing data through in this way, and this would be the same for a relational database, imaging, genomics data into a central graph, into a central processing point, you still have bottlenecks. As we found, it was slower than we wanted it to be, but it's also unidirectional. It's going in one way. And so we looked back at the brain. How does the brain tackle this challenge? So this is how you're seeing this image right now. Light is hitting your eye. Your retina is doing edge detection right away. It's not waiting for permission. It's happening in this moment. It's refining and passing that signal forward to your primary visual cortex. That's looking for shapes, looking for patterns, going to your higher level visual cortex for objects, faces, motion. It's pulling on your hippocampus for memory. I recognize this. It's pulling on your amygdala for emotion. This is safe. This is happening right now. And the fascinating thing about this structure is there's no central CPU to this. It's a distributed model. Each component has local intelligence. It is processing and refining and passing that forward to the next stage in continuous communication through the connectome. And so we asked ourselves again, what might this look like if it was deployed in our healthcare system? So there's a parallel we can draw. On the left, we have what I just went through, the eye, primary visual cortex, finding features about the face, and bringing an emergent understanding. That's my colleague. I can trust them. On the other side, what we would like to see is something where we're passing this refined signal through a series of stages, and imaging, if it was in that moment able to tell us there's an issue with cortical thickness, there's an issue with hippocampal volume, there may be a problem here. Similarly, that genomic stage, you want to know in that moment, this person might be a poor metabolizer of this drug. We need to change it. And so similarly, we want to create an emergent understanding through refining the signal. An alternative approach is needed. So we flip the script a little bit. Instead of having a purely centralized processing and that unidirectional flow, we've embedded the AI in a microservice model with streaming into those points of data. So in the imaging space, in the genomic space, in the clinical space, in constant communication with the knowledge graph. That's the connectome. And through this, we're trying to mirror the way in which the brain is actually able to process what it's processing right now. So we call these things synapses. They're living in different places. We can continue to build them wherever we think we need them to be. And a feature of this, again, similar to the brain, is that while those synapses are learning and we're deploying models in that context, the entire system is learning by writing that information back to that central knowledge graph, that central structure. And so we're seeing this continue to improve in its capacity to deliver those insights. Now, my team is very fortunate to also be building data platforms across the country. At the local level, we've built the Brain Health Data Bank, the Neuroinformatics platform. We have over 600,000 patients and about 50,000 participant data sets within those systems to analyze and refine. At the provincial level, we're linking data across different mental health hospitals, but also making the connection between the heart and the brain, that physical brain connection. And we're building a pan-Canadian youth data platform in every province and territory, as well as the 988 crisis line. And so in our development of these systems, we're also embedding these insights. They share a common structure of data models and interoperability capacity, but it's a way we can also imagine distributing this intelligence across a national network. So to bring it back together, in neuroscience, the brain has features of a connectome and a processome. Computation is not centralized, it's distributed in a dynamic way. In enterprise architecture, you may or may not agree, but often centralization is the bottleneck. Distributed computing has advantages. It's more robust, it's more flexible. And our healthcare reality is that decisions happen at the edges. They don't happen in a central place. They happen in that now moment, in that clinic, in that moment of crisis. And so at CAMH, we built a knowledge graph to help us organize the fractured data, particularly fractured in mental health. Used it by brain architecture as a principle to then create this additional level of a processome. And this is the blueprint that we've adopted. It might work for you, it might not work for you, but this is how we've thought about moving forward with this. So we'll close here. I really hope this has brought about some connections and some questions and some new ideas. I really appreciate everyone's attention today, and I'm looking forward to an exciting day 2 for those here and those who are online. Thank you so much for your attention.
We've got some time.
I know.
That's awesome. We never have time. Let's start with the floor. Any questions? I've got lots. Nobody? Oh, there we go.
So you talked about this model, this graph, and all the relationships. So you have like a physical, when you have like relational databases and then graphs on the
Here
other
comes the
side.
mic.
So
Oh, thank you.
do you have like a technology stack that allows you to manage that kind of data and their relationships in that graph? Can you talk about it more?
Yeah, of course. So we were very fortunate, and I was chatting. So our previous scientific director, Dr. Sean Hill, worked at the Blue Brain Project, and it was a massive project in Europe to try and actually replicate brain. It was meant to literally computationally, in silico, create brain structures. And they had a similar type of challenge. To do that, they had to pull together data from cells, from genes, all of these interesting properties, and they created something called the Blue Brain Nexus. And it is an open source, RDF-based knowledge graph stack. Some of the components we've had to switch out over time when they've gone not open source. But that is the core technology we've been using, both at the heart of our knowledge graph at CAMH and then some of the other national projects that I've talked about.
And now, so all your medical related data is stored in that format versus relational databases, or how do you, and you can exploit that? And I'm impressed. I just, it sounds super interesting.
It's a great question. So we have a representation of it within the knowledge graph, and we're trying to build up, really in a way, a representation of an entire patient and all of their biology, not trivial. We still use relational databases, of course. There's still standard reporting I have to do for the board. It's not going to go through the knowledge graph. It's going to go through this. But we're thinking for the problems we're trying to solve, this is one tool we can use that has advantages.
Thank you.
Any other questions that we see out there? Okay, my question was the technology, right? So again, we heard a lot from different organizations yesterday as to who's on premise, who's on cloud. What's the situation at CAMH?
So this is on-prem,
Yeah.
and we built this because we happen to have a lot of really good donor funding, I'll note, some really visionary philanthropy that allowed us to do this in a way I think would be very challenging for some sectors. So it's on-prem. We love cloud. We still use it, as I was saying, for other things. We're putting, finance data is in the cloud, but this is something that's really embedded within our enterprise.
So we talked a lot yesterday about scaling, right, and then innovation, stuff like that. So where do you see this going into the future? And what's the opportunity, right? So we think about, I mean, obviously CAMH, great center of excellence, but you and I chatted yesterday, right? There's centers up north, Waypoint, right? There's other centers to our east and stuff like that. So how do we bring this so that everybody has that same interconnectedness? How do you see that happening, or can it happen?
Yeah, I guess I see that in two ways. So I think we're very privileged to be in Toronto for many reasons, but we have data from a very rich and diverse population. And we've tried to design our studies so they aren't just focused on one population they historically have been, but to be broader. And so both in the nature of what we're designing as a function of what the brain is, that could benefit everyone. We're also looking at ways to scale up our research data collection. So how can you collect remote EEG, for example, quickly putting on a headband, getting valuable information. They don't have to sit in an MRI for a couple hours. That's hard to do. So we're trying to both create a model that might work for everyone insofar as we have data from different populations, but scale out the way in which we can enrich this with data from different areas nationally.
Any other questions? Okay, we got a question there. Otherwise, I'm going to bug you about commercialization.
Oh, yeah.
But we'll go here first.
Okay.
But to give you a warning.
Okay.
Hi, my name is Gabriel. I come from Kaihai. Thank you for your talk. It's very interesting. My question is, yes, imagine that you scale up this network, but to the healthcare data in Canada, right? There is some privacy regulation against linking data sets that will essentially prevent it. Right? How would you navigate that?
Yeah, it's a great question. So the technology we have can federate. So when I was talking about national platforms, we've built in the capability to interoperate. They share the same structure, so it's possible to do that. But the individual governance of those platforms is very fine-grained. So they may see only one data point. They're willing to open up to other people. In the context of the youth platform, there's a huge youth group that contributes to that to make decisions. We don't make those decisions, they do. And so to answer your question in short, we can share it, but it's functionally limited by what the governance requires and what is embedded into the permissions of that graph.
So is that, maybe to simplify it for those of us who didn't study neuroscience in our master's degree, is that like basically getting consent from everybody? Is that the way to simplify it?
So we track consent in the graph. So there's actually a graph data model for consent, and we tag that throughout. So we know when we can share and what we can share. So for example, at CAMH, we have our brain health data bank, and you can contribute your clinical data, you can contribute your MRI, you may not want to contribute your genomics. That's too far for me. So we track that, and then we can open up those data to people who want to use it, but limit those who are not.
Wow, that's interesting. And it's all by design, right? It's compliance by design, right? When you think about it in terms of...
Is Mary Jane here?
What's that?
Mary Jane.
Okay, so the question for me, private industry, right, is what's the opportunity for us to leverage some of this information? Of course, compliantly, right, and securely, and following all guidelines and stuff like that. But is there a future, you think, where private organizations would be able to access this data?
I hope so. Now, I'll of course preface it by the fact that the mental health population is the most vulnerable population in many respects. They often face homelessness, marginalization. Some people won't even talk about even mild conditions. So we have to be very careful when we're doing this. However, our hospital has endorsed the concept of data commercialization. And the reason why is, one, we can't do everything. We're a hospital. We can contribute in many ways to the intellectual development of this, but there's so much strength in industry. Can we make better drugs? We can't do it alone. And so we're very open to that.
Oh, interesting. Stuff like that. I'll go to the floor for one last question. Anything? The final question I have then is so you were showing us some screenshots. Would that be the actual screenshots, visualizations that physicians are seeing when a patient comes into the emergency room? Are they that laid out?
It's quite similar. Actually, the design is similar.
Okay.
So we have the trajectories. Depending on the nature of the disorder in that moment, it might be different. So you may see more than one scale, but that sort of time course is a fundamental component of the design. I should say they're all co-designed with clinicians and patients to see what makes sense for them. What I showed you is not real patient data.
Sure, of course, yeah. Okay, thank you very much, sir. That was
Thanks
fantastic.
again. Thank you.